Today's presentation will be on Hidradenitis suppurativa. This is based on a JAAD CME journal published online on October 2019. This is part 1 of 2, and the second part will be discussed by Dr. George Paloma. So the following are the learning objectives to define Hidradenitis suppurativa or HS, learn the epidemiology, comorbidities, risk factors, and diagnostic criteria of HS, recognize the clinical presentation of HS, and understand the pathophysiology of HS. Here's a brief outline of the specific topics we will be talking about. Based on the journal, the definition of HS would be as follows. It is a chronic, inflammatory, recurrent, debilitating skin follicular disease that usually presents after puberty, with painful, deep-seated inflamed lesions in the apocrine gland-bearing areas of the body, most commonly the axillary, inguinal, and anogenital regions. According to the journal, there is agreement that diagnosis requires a history of at least 5 typical lesions, consisting of erythematous papules, nodules, or abscesses in flexural sites, with recurring nature over time. This is in contrast to the diagnostic criteria in our textbook Fitzpatrick's Dermatology 9th edition from Table 84-1, which states that it requires a typical lesion, one or more, consisting of painful nodules, abscesses, draining sinuses, double open comedones, and bridged scars, with a typical distribution on the axilla, groin, buttocks, perineal, and inframammary regions. So in cases of atypical or ectopic sites, at least one typical area must be involved, and chronicity and recurrence, which is suggested to be measured by having 2 recurrences over a 6-month period. For the epidemiology, the prevalence of HS is unknown, but estimates range from 0.00033% to 4.1%. It frequently occurs in young adults, and it is more than twice as common in women compared to men, and is more common in African Americans and biracial individuals than Caucasians. So for the quality of life, this is significantly decreased. Depression and pain are also associated with this condition. Depression actually occurs in 5.9 to 42.9% of patients in both pediatric and adult populations, and the pain that was said to affect up to 90% of patients is worse compared to psoriasis and other diseases. So this leads to social and work impairment. For the presentation and clinical classification, HS is diagnosed clinically and pathologic confirmation is unnecessary. So let's move on to the definition of the characteristic lesion. So these would include deep-seated nodules, abscesses, and sinus tracts that rupture and form scars. So initial lesions are blind boils, which can progress to draining sinuses, bridged scars, and open tombstone comedones. So for the areas of predilection, the lesions favor the axilla and inguinal area, but also occur in the submammary folds, perineal area, buttocks, mons pubis, scalp, post-auricular area, and back. There is often a significant delay between symptom onset and the establishment of diagnosis, with an average of 7.2 years, which underscores the need for familiarity with the above diagnostic criteria. And most patients have more than one lesion at the time of diagnosis. So for the accompanying symptoms, the lesions are usually accompanied by discomfort, pruritus, and pain. Many patients experience prodromal pain symptoms. Factors including heat, sweating, physical activity, shaving, and friction exacerbate the said symptoms, and these acute exacerbations alternate with periods of quiescence. So there are various classification systems for HS as shown in this table, but among these, the Hurley staging system is the most widely used, because this has been shown to have good inter-rater reliability and is considered an acceptable instrument for the classification of HS, while as the other classification systems mentioned here have been found to have lower agreement between assessors. Therefore, I would be discussing the Hurley staging system in detail. So, this is a three-stage classification of disease severity designed to help select treatment. Unfortunately, it fails to assess disease activity or treatment response. So for stage 1, the description would be single or multiple isolated abscesses without sinus tracts or scarring. Stage 2 is defined as recurrent abscesses with 1 plus sinus tracts and scarring separated by normal skin, while as stage 3 is defined by the presence of diffuse boils with multiple interconnected sinus tracts and no intervening normal skin. There are also several clinically distinct HS phenotypes, and we will be discussing these one by one. So these distinct subtypes are not based on disease severity. So all three of the Hurley stages can occur in each type. So for the first type, the regular type, it is the most common and consists of patients who fulfill the diagnostic criteria for HS but lack other specific characteristics. Next would be the frictional furuncle type. This features lesions in frictional sites in patients who are overweight. Next would be the scarring folliculitis type. So this would be the regular HS with the presence of pustule cysts, superficial nodules, depressed cribriform scarring, and double-ended comedones. So these are frequently found on the buttocks, inguinal region, and pubic region. Scarring typically occurs and usually occurs in overweight patients who smoke. Next would be the conglobata type. So it consists of cyst and acne conglobata primarily on the face and trunk in men who are not overweight. This type is also usually familial. Gamma secretase mutations were found in this group, and they are usually found to have a more severe Hurley classification. Another would be the syndromic type. So it could occur with PASH or PAPASH. So PASH consists of pyoderma gangrenosum, acne, and HS, whereas PAPASH would be PASH with the addition of pyogenic arthritis. And lastly, the ectopic type, which involves the face. So although these phenotypes do not guide therapeutic decisions, consideration of these phenotypes may help optimize disease management. So HS is associated with many comorbidities, most of which are inflammatory in nature, and they have an incredibly high comorbidity burden. So hypertension, obesity, dyslipidemia, thyroid disorder, arthropathies, psychiatric disorders, and polycystic ovarian syndrome have all been independently associated with HS. But obesity is the most common comorbidity associated with HS. Obesity increases the pro-inflammatory response, and high BMI patients have higher Hurley scores, more affected areas, and worse self-reported severity compared to low BMI patients. So there is a strong association between HS and tobacco smoking, although a causal relationship has not really been established. So the prevalence of smoking is estimated to be 70 to 90%, and the odds ratio of a new HS diagnosis increases by 90% among tobacco smokers compared to non-smokers after adjusting for age, sex, race, and obesity. Smoking also appears to correlate with obesity, as 75% of tobacco smokers diagnosed with HS are obese. There is also an increased prevalence of HS among psoriasis patients. So, a study of 68,836 psoriasis patients found that HS prevalence was increased in patients with psoriasis compared to age, sex, and ethnicity matched controls of 0.3% versus 0.2%. So the difference remains statistically significant after adjusting for smoking, obesity, and additional comorbidities. Psoriasis patients with coexistent HS are younger and have a higher prevalence of obesity and smoking. Several other conditions associated with a pro-inflammatory state have also been associated with HS. There is a 3.5% incidence of obstructive sleep apnea in patients with HS versus 2.5% in those without HS. Inflammatory bowel disease, particularly Crohn's disease, also has possible epidemiologic and pathogenic connections with HS. Analysis from 4 studies found HS prevalence in IBD and CD patients to be 12.8% and 17.3% respectively. Inflammatory arthritis also has a higher prevalence in HS populations compared to the general population, and in a prospective study of 640 patients, 3.7% had comorbid spondyloarthritis, and of those patients, HS preceded articular symptoms in over 90%. HS is a component of the follicular occlusion triad or tetrad. So, the conditions acne conglobata with dissecting cellulitis and HS comprises the follicular occlusion triad. And if you add the presence of pilonidal cysts, that would constitute the follicular occlusion tetrad. So HS and acne can also be components of autoinflammatory syndromes such as PASH and PAPASH, which was discussed earlier. And finally, chronic HS can transform into squamous cell carcinoma. The prevalence of SCC associated with HS is approximately 4.6%. So moving on to the pathogenesis, the mechanism of lesion formation in HS centers around the pilosebaceous apocrine unit, which contains a hair follicle associated with sebaceous and apocrine glands. Sebaceous glands secrete sebum, a group of complex oils that lubricate the skin, whereas apocrine glands drain oily sweat through a dermal duct that passes through the hair follicle by a coiled acrosyringium above the sebaceous gland. So initially, apocrine gland inflammation was proposed to be the primary event in HS. However, newer research suggests that it's actually follicular hyperkeratosis that occurs first, causing plugging and dilation that results in follicle rupture with subsequent inflammation, abscess, and sinus tract formation. Apocrine involvement appears secondary to dermal inflammation. HS patients have no change in apocrine gland size, density, or distribution compared to healthy controls, but do tend to have a reduced volume of sebaceous glands. So the immunopathogenesis of HS is complex and is still being elucidated, but several cytokines appear to be particularly relevant. So these are TNF-alpha and IL-7, because levels of these and serum levels correlate with disease severity. So first is tumor necrosis factor alpha. TNF-alpha is secreted by both the innate and adaptive immune cells and is elevated in inflammatory diseases including rheumatoid arthritis, inflammatory bowel disease, and psoriasis. But it is significantly increased in HS patients compared to healthy controls, and psoriasis patients, and TNF-alpha levels increases with increasing severity. So, the role of TNF-alpha is multifactorial. First, it increases the ratio of the Th17 to regulatory T cells. This in turn results in increased production of Th17 cells, disease-relevant cytokines. Second, TNF Alpha acts on adipocytes and muscle cells to induce insulin signaling defects and suppresses the secretion of adiponectin from adipocytes. So, adiponectin is an anti inflammatory hormone that regulates glucose metabolism and insulin sensitivity. It is negatively correlated with BMI. Decreasing circulating levels are associated with diabetes and metabolic syndrome. So, it has been found that adiponectin levels are significantly decreased in HS patients, in part because of the elevated TNF alpha, which also predisposes to insulin resistance. Third, the relationship between smoking and HS is thought to involve TNF alpha. Nicotine increases eccrine gland secretion, and nicotine excretion in sweat induces TNF alpha release by keratinocytes and Th17 cells. Besides that, nicotine also induces infundibular epithelial hyperplasia, causing follicular occlusion and rupture. And fourth, upregulation of toll-like receptors and matrix metalloproteases has been observed in HS. So TLRs are important for generating innate immune responses. TLR4 more specifically helps activate gene expression, resulting in production of pro-inflammatory cytokines, which also includes TNF alpha. While as MMPs also activate inflammatory effectors and directly lead to tissue injury. MMP2 specifically is also activated by the TNF alpha, and MMP9 is induced by the different toll-like receptors. Another important cytokine in the pathogenesis of hidradenitis suppurativa would be interleukin 17. So this comes from the Th17 cells, which develop from IL-23 stimulated CD4 T cells and are the main producers of interleukin 17A. So, these Th17 cells are increased in lesional and perilesional HS skin compared to healthy individuals. IL-17 induces the expression of IL-1 beta, IL-6, and TNF alpha through a mechanism involving the non-like receptor protein 3 inflammasome. And IL-17 in turn increases macrophage production of IL-1 beta and TNF alpha, thus further enhancing the immune response. These are the other cytokines involved. IL-12 and IL-23 are heterodimeric cytokines that share a common subunit, which is P40, and play a role in the establishment of chronic inflammation. IL-36, primarily expressed from keratinocytes and monocytes, is involved in innate and adaptive immunity. Concentrations of IL-36 are significantly higher in HS lesions compared to healthy adults. IL-6 is a pro-inflammatory cytokine that promotes B-cell antibody production and is involved in multiple inflammatory conditions. Elevated levels of IL-6 and its receptor have been detected in HS skin, especially in early stage 2 to 3 patients compared to healthy controls. So with regards to hormones, its role in HS pathogenesis remains unclear because hyperandrogenism is usually absent in HS. The role of female hormones is also unclear, but the journal noted that up to 43% of female HS patients experience worsening symptoms around menses, and contraceptives containing progesterone appear to worsen HS, potentially due to their androgen-like effects. Next would be the role of sphingolipids. So sphingolipids are membrane lipid signaling molecules. There are 3 main types: the ceramides, sphingomyelins, and glycosphingolipids. HS lesional skin was found to demonstrate decreased expression of enzymes that generate ceramide and sphingomyelin, as well as increased expression of enzymes that catabolize ceramide. Decreasing ceramide and sphingomyelin levels would disrupt the cutaneous barrier and cause immune activation. Next would be the role of genetics in HS. So 30 to 40% of HS patients have at least one affected family member, supporting a genetic predisposition. So mutations in NCSTN, PSEN1, and PSENEN genes are involved in gamma secretase production, which is essential for normal immune system function and maturation of hair follicles. So in families with these mutations, HS follows an autosomal dominant inheritance pattern with incomplete penetrance, and affected members tend to have a more severe phenotype. Next would be the role of bacterial colonization in HS pathogenesis. So the cutaneous microbiome is significantly different in HS lesional skin, non-lesional skin, and patients without HS. So the lesional skin microbiome consists predominantly of Corynebacterium, Porphyromonas, and Peptonephelus species, while non-lesional skin has predominantly Acinetobacter and Moraxella. P. acnes is reduced in HS skin, potentially allowing pathogenic bacteria to flourish. Data involving the presence of Staphylococcus aureus in HS is inconsistent. Some groups have observed S. aureus in HS lesions, but others have not, likely due to the anaerobic nature deep within the lesions. And lastly, biofilm aggregates occur in 67 to 75% of sinus tracts and infundibula and are larger in lesional than perilesional skin. So in conclusion, HS is a debilitating condition that stems from follicular hyperkeratosis and apocrine gland inflammation. Patients are frequently smokers, obese, and report pain and a significantly decreased quality of life. HS pathogenesis involves immune dysregulation with inflammatory cytokines, specifically TNF-alpha and IL-17, playing important roles, likely with an underlying genetic predisposition and distinct microbiome. Increased understanding of the immunopathogenesis has paved the way for the development of new targeted treatment options for the disease. Thank you.